Pharmacology and Aging. When used appropriately, medications can enhance one's quality of life at every level. When used inappropriately, medications threaten the most basic level of physiological stability. Physiological changes that can influence the drug response can include a decreased absorptive surface, decreased gastrointestinal activity, decreased cardiac output, decreased lean body mass, decreased gastric pH, decreased total body water content, decreased renal blood flow, decreased liver function, and increased body fat. So as a result, absorption is going to be slowed or extended. Distribution, due to the increased body fat, we have to understand that many drugs are stored in body fat, so this can increase serum levels. Metabolism, we see decreased liver function, so it may require dosage adjustment. And excretion, we have decreased kidney function, so the drug stays in the system longer. The route is going to cause the absorption rate to vary. Remember that oral medications absorb the most slowly. The physiological changes can also affect the rate. We have the increased gastric pH is going to retard acid-dependent drugs. Stomach emptying is delayed, and intestinal motility is slowed. If GI motility is slowed, then there's an increased contact time with the medication, which leads to an increased amount absorbed and an increased drug effect. Distribution is going to depend on the plasma protein, as drugs tend to bind or need to bind with protein prior to distribution. Potential alterations of drug distribution in late life are related to changes in the body composition. With aging, the liver's activity, mass, volume, and blood flow are reduced, which result in potential decrease in the ability to metabolize drugs. Hepatic clearance of medication is actually decreased 30 to 40% in the older adult. And kidney function decreases with aging, up to 50% by the age of 80. So this will prolong the time required to eliminate the drug, so the drug is going to work in the system longer. Drug interactions can also include herbal preparations. So let's look at some drug-related problems in the older adult. First of all, we look at chronopharmacology. This is relations of biological rhythms to the variations in the body's response to drugs. It's a developing science that may lead to more effective drug therapy. Polypharmacy is multiple drug use and may be duplicated or unnecessary drugs. There is an increased risk for drug interactions and an increased risk for adverse events. Taking 5 or more medications at the same time is considered to be polypharmacy. You need to routinely monitor the number of prescriptions and non-prescription medications used and determine if they can be eliminated or combined. Keep the use of medications to a minimum when at all possible. Overprescribing medications leads to increased problems with more side effects, increased interaction among medications, replication of medication treatment, and diminished quality of life and pointless costs. So we need to assess for medication interactions and also recommend the use of only one pharmacy. Drug interactions are where drugs can potentiate one or another or make one or both more or less effective. They include interactions with food, supplements, and alcohol. It's vital that the nurse monitors the medications that he or she administers for the potential of drug interactions and needs to encourage all those under his or her care to do the same. Instruct the client to talk with the pharmacist regarding drug interactions if a new medication is prescribed. Adverse drug reactions can range from minor annoyances to unwanted pharmacological effects, including death, and they are unpredictable. Monitor closely for unwanted pharmacological effects due to potential drug toxicity. The common sign of an adverse reaction is acute mental status change. Inappropriate prescribing is medication potential for harm. Is greater than potential benefits. Dosages are usually prescribed at 1/3 to 1/2 the usual dosage for the older adult. Misuse of drugs can be accidental due to misunderstanding of directions, an inability to read the label, memory failure, inadequate skills of the nurse or the prescriber, or inadequate funds to purchase prescribed medications. Misuse of drugs can include overuse, underuse, erratic use, and contraindicated use. And administration. We need to make sure that we put the client in a sitting position when at all possible. Check the mouth for dryness, because medications can stick to the inner surfaces of the mouth. Administer liquid preparations if the client has difficulty swallowing pills, or crush tablets as necessary. You can also give them with a textured food. Understand that some medications may not be crushable, and check with pharmacy or drug books if necessary. For example, enteric-coated tablets and capsules should never be crushed. Do not administer suppositories immediately after removing from the refrigerator. If you decrease the body core temperature, suppositories can take longer to dissolve. When administering parenteral medications, monitor the site for leaking of medication or bleeding due to decreased tissue elasticity. And do not use immobile limbs for administration of parenteral medications. Monitor the client for compliance while taking prescribed medications, and monitor the client for safety with regard to correctly taking medications, including being able to read the labels and or to tell pills apart. Consider the use of medication cassettes for the administration of medications. As you have worked in the long-term care facilities, you have probably seen Beer's criteria, and this basically identifies drugs that carry a higher than usual risk when used in older adults. So let's look at some specific medications that may cause some concerns if administered in the older adult. Under hypnotics, we have Dalmane and Dorol. These are not recommended for clients over 65 years of age because drug hangover is a problem. Restoril is considered safe for the elderly. It is absorbed slowly, so it should be administered 1 to 2 hours prior to bedtime. And if taken with food, its action will be delayed. Haldol is also considered safe for the elderly. Its dose should be tapered rather than stopped abruptly. And benzodiazepines such as lorazepam and oxazepam can be used for insomnia and should be administered 1 hour prior to bedtime. With diuretics, the dose is usually reduced for older adults due to dose-related side effects. With antihypertensives, drug classifications that are used in the treatment of hypertension include the diuretics, the beta-adrenergic blockers or antagonists, calcium channel blockers, ACE inhibitors, the angiotensin II blockers, and centrally acting alpha-2 agonists. Now, the calcium channel blockers, ACE inhibitors, and the A2 blockers are frequently the drugs of choice because there's a low incidence of CNS side effects and electrolyte imbalances in the elderly. Antihypertensive dosing is usually started with a reduced dose that is gradually increased to the appropriate level. And due to adverse reactions such as orthostatic hypotension, alpha-1 blockers or antagonists, and centrally acting alpha-1 acting alpha-2 agonists are usually avoided in the elderly. Cardiac glycosides are excreted by the kidneys, so kidney function may cause an accumulation, or so decreased kidney function can cause an accumulation of the drug. It's usually considered safe for the elderly client as long as it is appropriately monitored. As with anticoagulants, you always need to monitor for bleeding. With antibacterials, realize that there's some antibacterials that may need to be administered in reduced doses. Tagamet is not recommended for administration in the elderly client due to its side effects and multiple potential drug interactions. And laxatives, realize that fluid and electrolyte imbalances can occur with excessive use, and it can cause a decreased drug absorption. Drug dosages of antidepressants should be gradually increased until the therapeutic level is reached. Close monitoring for potential adverse effects is very important in the administration of antidepressants in the elderly. Tricyclic antidepressants are generally effective in the geriatric population, but they have anticholinergic properties and can have some side effects, such as dry mouth, tachycardia, constipation, and urinary retention. And it can also contribute to narrow-angle glaucoma. Prozac is a bicyclic antidepressant that has fewer side effects, and those are usually dose-related. The MAOIs have adverse reactions such as drug-food interactions that can result in hypertensive crises and severe orthostatic hypotension, and it's not often prescribed for the older client. And Elavil or amitriptyline is not recommended for the geriatric population. Hypotension and respiratory depression may result from narcotic use in the older client, so close monitoring of vital signs is essential. It is not recommended for the geriatric population to receive Toradol, Demerol, or Darvon. Additional drugs not recommended for the geriatric client can include antihistamines because they can be highly sedating, antispasmodics due to the anticholinergic effects, muscle relaxants due to the anticholinergic effects and sedation, and sedatives because of prolonged sedation. Again, you have to be aware of the routes of elimination and implications of aging on your clients, and be aware of the effects and signs and symptoms of toxicity. Older adults do not process medications the same as younger adults. There are differences, and you as a nurse must be aware of these differences. And challenges to medication compliance include the 5 rights, the client's functional status, their physical status, sensory status, their ability to read, their memory or their cognitive status, how motivated are they to improve their status, and do they have the appropriate funds to purchase the medication that has been prescribed.